Welcome to the Birth Launch Podcast, an empowering space for expecting and new parents to hear candid conversations with experts and learn how to craft your ideal birth. We will tackle the scary and weird questions that come up along the way and provide answers that are driven by science and evidence-based recommendations. I'm going to show you how to redefine parenthood and choose what's best aligned for you and your goals. With 10 years of experience in family education and a master's degree in human development and family studies, I'm ready to help you navigate pregnancy and explore your birth options to free yourself of fear surrounding childbirth. My goal is to help you have an informed and confident labor experience, plus an empowered and joyous postpartum. Caitlyn, welcome to the show.
Hi, thanks for having me.
Absolutely. I'm so excited to talk to you today. And I also think this is a conversation that a lot of people want to have, and we see it online happening a lot. Good information a lot of the times. Sometimes bad information gets out there. So I wanted to have you on today to talk about electronic fetal monitoring, what it is, why we do it, what our options are. If you don't want it, let's know what the boundaries are around that. What are some things that might happen in your labor where it might be required, or also you might really want that information. So thank you for being here. I'm excited to share your wisdom with our audience. And I think that a good place to start probably is just, what is electronic fetal monitoring and why do we do it? What are we gaining? What information are we getting from that?
Sure. Yeah, electronic fetal monitoring is something that's only done in the hospital setting. We can't do it in the home birth setting or even in the birth center setting. When we do monitoring of the baby's heart rate in those settings, it's more with a Doppler. We call it intermittent auscultation. So if you're ever looking at like the evidence, you want to do some of your own research, your own digging, those words can be helpful in trying to figure out like what it is that you're looking at. But for electronic fetal heart monitoring, again, happens only in the hospital, and there's a few different ways that we do it. There is a continuous fetal heart monitoring that's oftentimes like considered the default in most hospitals, at least in the United States. And it's where we're looking at the baby's heartbeat rate really continuously over time. And what you'll notice when you go into like labor and delivery, if you're going to be monitored this way, they'll put monitors on your belly, and there will likely be a screen that you can see that you'll see your baby's heartbeat being monitored, and it creates a line on the screen, or it ends up being like a jiggity jaggedy line that's like all over the place. And usually that's good. It's a good thing, right? When we got like all the movement going on in that line, but it's creating a line which is just a continuous recording of your baby's heartbeat over time. But yeah, that's continuous, right? Continuous fetal heart monitoring. And then you have intermittent fetal heart monitoring, which is essentially the same thing except for periods of time. And then you are taken off the monitor, meaning that those monitors that are on your belly are taken off, and you're able to move around the room without being tethered to anything, without having anything bothering your skin or on your body. And as long as everything's looking fine and you're low risk, it can be very reasonable to use that approach where we're looking and then we're not looking. The big difference really, in my eyes, with those two different approaches is one of them, you're like under the microscope, you're being watched the whole time. And the other one, you're getting breaks from being watched. And of course, you have the benefit of movement, but there's other ways to get that benefit with monitoring. The big difference really is just being watched. And we know that sometimes being watched is not always our best friend.
Mm-hmm. Yeah. So why do you think the default is to do continuous monitoring? Do you think it's because it does require a lot less kind of manpower, nurse power in and out of the room? Or is there a benefit that would make that the default?
I don't think that the primary reason is because of like less manpower, because,
Mm-hmm.
your labor and delivery nurse has to record, they have to keep up with that in terms of charting when you're being monitored continuously. They're constantly putting that into the record. And there can be actually some, break really when you have intermittent monitoring going on. It's less work for them at times when they've got that time that you're not being watched. I think the main reason why it's the default is liability. I think that's a big part of it. I think part of it too is just knowing the history of obstetrics and like how we went like really far into like medical intervention
Hmm.
to the extreme where we can almost just objectively say that it was. I don't think anyone argues that there was a time in our not distant past where it was pretty terrible. And I do believe that a lot of what we have going on now that's not supported by evidence is remnants of a time when things were vastly over medicalized. And we've gotten so much better since then, but we still have things like this where we see the studies and we know that for certain people, it's not the best choice to watch baby the whole time. And it leads to problems and intervention and harm, really, to patients when we could maybe individualize our care a little bit and make sure
Yeah.
that certain people are getting the care that makes sense for their risk profile.
Yeah. Who are those people that you're talking about that it may actually not be the best option? Are you talking about low risk people, low risk pregnancy, low risk labors?
Yes, exactly. So
Yeah.
yeah, you're pregnant, you haven't been diagnosed with anything. And this includes post dates, like you've gone past your due date. That's not,
High
I sometimes,
risk.
that's not high risk. There's certain things that we get a little confused about. For me, I went in for my most recent birth 3 months ago, and I was post dates. I was 40 weeks and 5 days when I came in, and the anesthesiologist, when she was consenting me for my like all any anesthesia that I might need during the course of my labor, was like, "Any problems other than the fact that you're post dates?" I'm like, that is not a
Okay.
problem. That is normal. 50% of people will not go into labor by 40 weeks and 5 days. I'm like, I am literally in the median right there. But no, yeah, if you're low risk, if you haven't been diagnosed with something like hypertension or gestational diabetes or these big ticket, they're diseases, they're disease processes.
Yeah.
If you're just like a normal pregnant person, the studies don't support you having continuous monitoring unless something changes, right? You come in, you get intermittent monitoring, your baby's heart rate's doing some weird stuff, then you might get switched to continuous monitoring.
Okay, so you were talking about it being intermittent and that there's periods of times where we take a break. How long are those periods of time? How often are we checking in on baby? And then can you tell us what that looks like? They put the paddles on your belly, you sit for a certain amount of time.
Yeah, so it changes throughout your labor, and it's also variable based on facility. Sometimes
Hmm.
they'll typically monitor for maybe 20 minutes, have you off for 40, and then when you get closer to the end, that oftentimes becomes a lot more regular. Like, for example, when you're pushing, they'll be monitoring baby's heart rate with each contraction, each push as you get closer. So typically, yeah, it's these monitors that are connected to a machine that's stationary. And because you have to get a stretch of time where we're watching the baby's heartbeat and it's not being interrupted, it's not going off the monitor for periods of time or whatever, most of the time people will choose to stay in bed during those stretches of time where they're watching in order to minimize disruptions that would cause you to have to be monitored for longer. So I have recognized that is one small downside to intermittent monitoring is that when you're getting, for example, continuous monitoring with a portable monitor, there's not really like any interruption to the labor in terms of let's get into bed and sit here for 20 minutes and watch the baby's heartbeat and then we'll unplug you and let you go or whatever. But it really, I think it just comes down to personal preference. And again, that thought process of, I think a lot of people think it's just about movement, but it's not just about movement. It's also about baby being watched, because that's really what oftentimes causes like that cascade of intervention. Just to elaborate a little bit on that, if you can take, for example, you are being monitored and baby's heart rate drops suddenly. Everything's fine, right? Like nothing crazy's been happening, but all of a sudden your baby's heart rate drops. We could potentially respond with medication. Sometimes in very dramatic cases, we might respond with a full-blown C-section and major abdominal surgery done in a very rushed fashion based on this thing that we see on the monitor. But it's argued, like some people will argue, that maybe babies do that all the time, but we are not watching them at 37 weeks or when you're just hanging out pregnant. But when we're watching, it's not even so much that your providers and your nurses don't recognize that this could potentially just be like a normal variation in this moment in time that's going to resolve. It's not even that they don't recognize that. It's that they have an obligation to respond because we've got liability and we've got their jobs are on the line. If they don't respond to something that they see because they have this information being given to them, right, from the monitor, if they're not using that information and responding similarly to how other providers like them would respond in that same situation, they are maybe will find themselves in court, and there will be other providers saying, if I saw that variation, I would have done this or that. And so if they don't pull you back for that C-section or give you that medication and something does go wrong, they're going to be questioned on that. Their judgment's going to be called into question. And so that's the really tricky part of it. The more information you give to your providers, the more that they are obligated to use it.
Dang, that's tough because you don't want to be secretive. You don't want to not tell your provider things. You want this open communication, but then it does open them up to a place of now my hands are tied. And we see that in so many places in maternity care. That's really too bad.
Yeah, it's really fascinating to me because it took me a long time. I worked as a doula for a while. It took me a long time, even after working as a doula, to see it from that perspective of that you could have the best doctor, best midwife in the world. You love them, you trust them. They're so compassionate. They listen to you, they respect your choices. But that same midwife or doctor has to wrestle with the choice to respond to things because they are obligated to, because it's hospital policy, because it's expected of them, even when they know most likely it'll be fine, most likely, but it's not certain. And so they have to think, well, am I going to respond to this the way that I'm expected to respond to this, keep my job, keep the liability low, and then continue to treat patients in the future and be able to have a good impact on patients in the future? Like even your best, most wonderful providers and midwives and doctors, all that, are still going to struggle with this no matter what. So you might love your doctor. My doctor would never do something that they didn't think was absolutely necessary, but sometimes they have to in order to continue to exist in this setting. So it does, unfortunately, put the onus a little bit back on us to say, okay, how much information am I going to put out there? And in some ways, it can actually be some grace to not give your provider every piece of information that can be had, because then you're not putting them in a position where they have to make some of those calls
Yeah.
when they maybe know in the back of their mind that everything would have been fine.
Yeah. And that paints a beautiful picture of how continuous fetal monitoring actually has led to an increase in C-section over the last couple of decades after it was introduced, right?
It makes a lot of sense, right?
Yeah.
Because if we're watching all the time and babies, like I said, a lot of people would say, hey, I think babies' heart rates just do weird stuff sometimes. Their neurological system is not very well developed. They need a lot of time before their body, their neurological system can regulate that sympathetic response that they're having. Yeah, when you're watching the whole time and we see these little quirks and all of that, it's really going to depend on like how trigger shy your nurse or your provider that's on call at that particular time at that particular hospital is. And so we might, end up with certain interventions that in a different circumstance, if you came in a little bit later and we didn't see that little blip on the monitor or whatever, you were doing intermittent monitoring, we wouldn't have seen it, would have maybe produced a different outcome. And
Mm-hmm.
so we see that for low risk people, we're talking low risk here, for low risk people, when we compare continuous fetal monitoring with intermittent, we don't see an improvement in outcomes, but we do see, like what you were saying, an increase in interventions like cesarean. So that kind of tells you all you need to know. Like, why would that be
Yeah.
happening? And that's really what we all recognize. Providers and nurses, most of us recognize that.
Yet the default is still continuous. That's what kind of blows my mind is like everybody knows that intermittent auscultation is better or this intermittent fetal monitoring is better, but we do the continuous because it's so
Exactly.
frustrating to me.
Exactly. Yeah. If your hospital, if you put yourself in the shoes of a midwife, right? Your hospital expects you to do this, right? Your continuous monitoring, right? And your patient doesn't come in and ask for anything different. Like, why? What would your justification be in a situation where all of your colleagues are doing it one way and you're the only midwife doing it differently, what would your justification be? Like, it's almost nice from that perspective when a patient comes in and says, no, I'd actually like to do intermittent. Because then they can go right in the chart, patient
Mm.
requested intermittent. What can I do about that? That's what they wanted. I respect their choices.
So
So
is
it's
there not
frustrating.
is there not a space for that midwife to do things who wants to do things differently to sit her patients down and say, hey, it's hospital. Now that you're here, congratulations, we're going to have this baby. We've got a couple options on how we're going to monitor your baby. Monitoring your baby is important. The hospital wants you to do continuous fetal monitoring. You do have another option. It's intermittent fetal monitoring. Let's go over benefits and risk. Which one of these feels better to you? And then that midwife had the justification to say, I'm obligated to educate my patients. I did that. They chose intermittent. Is that, of course, I'm not a medical provider. So is there no space for that really? Is that kind of taboo? Would that like really rub people the wrong way?
No, there absolutely is space for that. That is exactly what every midwife, doctor, provider should be doing.
Mm,
Now, the devil's advocate side is to say there's not a lot of time.
mm,
They're stretched very thin, both on the inpatient side with all of the patients that they jam pack into these hospitals, and then on the outpatient side with these appointments that are happening every 10, 15 minutes. Where is the time to educate people thoroughly? There oftentimes isn't a lot of time, but the correct approach, in my opinion, is to do exactly that. Educate them on both of their options and allow them to choose, and then document whatever it is that they choose. I
totally.
do think that some providers, maybe who don't see things the exact same way as maybe me and you do,
Yeah,
get pulled into this culture that prevents them from seeing that as like the
sure.
obvious choice. But that's just, I think, when you're surrounded by other people who are all doing it one way, it's hard, I think, for human beings to go a different path.
Totally. I resonate with that. Look, every time I speak up, I get sweaty and I'm like, all right, you can do this. You can do this. Like, you can do this. I understand it's really hard to go against the grain, but sometimes you just have to. All right. So I do have a couple of questions about the ways that we monitor. Doppler versus the paddle. Can you explain those to us? Why would we not have the paddles in a birth center, and why don't some hospitals have Doppler? So for the record, our hospitals in Boston, some of them do have Doppler. So just ask at your hospital. Some hospitals have wireless too. Caitlin, have you seen the monitor that looks like a spider and it sticks to their belly?
I
So
had that. That was mine.
cool. Oh, you
I
do?
only opted
Very
for,
cool.
yeah.
Very cool. So different hospitals have different monitors, you guys. So just ask what your options are going to be. Ask what they have. Like, how is that going to impact my movement? How is that going to impact? Or do you also see different, not accuracies, but more disruptions? Like what you were talking about in the bed, the paddles can, or if you're mobile, the paddles can slip off. So a lot of people opt to stay in the bed. The sticker ones are Wi-Fi slash Bluetooth. So if any of that is disrupted, you lose your feed to that. We've experienced that. So just think about those things. Doppler versus paddles. That was my question. Could you explain that to people?
Yeah. So, like you were saying, the Novi or the Monica, different places call it different things, but it's essentially something that sticks to your belly. And yeah, it operates off of mostly Bluetooth, I think, because your providers will turn their Bluetooth off to make sure that they don't disrupt it, because it can oftentimes get disrupted. And it also doesn't work at certain points in pregnancy. If you're coming in for preterm labor, you might not be able to use it. Sometimes also, depending on your body habitus and body size, it may or may not work as well. The other downside to that I learned the hard way is that some people have a really strong reaction to the
Oh,
glue or the application of it. I don't even know if it's like an allergic response. It's like they have to almost, in a small way, like sandpaper little bits
yeah.
of your skin to get it to stick right. And that, for me, this was my personal experience. It's not everyone's experience, but my partum, like that was more painful than the fundal massages because it was so sensitive. It was
Wow.
like your skin just reacted very strongly to it.
Mm.
But that is one form of continuous portable monitoring, essentially. So again, when you're thinking about what kind of monitoring you want, there's two kind of ways you have to be thinking about it. You have to be thinking about, do I want my providers constantly seeing my baby on the monitor? And then thinking about movement. right? So you can, if you want your baby to be watched the whole time, sometimes people feel much more at ease with that, right?
Totally.
If you want your baby to be watched the whole time, but you don't want your movement to be limited, then a lot of hospitals have things like the Monica, the Novi. They also have, some hospitals, not all, will have a monitoring, it's almost like a little purse you hold over your shoulder, and it connects with wires to the monitors that are on your belly. And it's essentially just standard traditional monitoring, except you can carry the monitor with you rather than having the one that's like huge and heavy and that has to stay in one place, right? But yeah, those are like your portable monitoring options. As far as the like just traditional default, most people get this unless they're requesting something different, is paddles, like little, usually little circular paddles. One of them is going to monitor your baby's heartbeat. One of them is going to monitor your contractions and how often they're happening, because we use the information from both of those together to figure out maybe a little bit of what's maybe happening in there. Those go on your belly. They're oftentimes connected to wires that go to that monitor by the bedside. It means that you might be tethered to the point where you can't get out of bed or leave far away from the bed. Some people will sit on a ball or do some positions right next to the monitor, but it does limit your movement a little bit. The other thing about those two, just to know, is that a lot of them are waterproof, and a lot of times, like with the Novi, for example, your nurses can put a plastic covering over it so you can get in the tub or you can get in the shower. Not every nurse is going to know that, and not every like place is going to tell you that that's an option. So that's something you can ask about as well. What did I miss? I feel like I'm missing something.
I
I
don't
didn't
think
answer your
anything.
question.
Yeah, no, I just learned so much. We see a lot of intermittent fetal monitoring with wireless paddles, and they do the strips and then they get off for a little bit and then they come back and they do more strips. And a lot of times it doesn't impede like our range of motion, but the biggest problem is like what you said, they just slip off the belly so easy. And so then you have a nurse who is like really frustrated. The mom is really frustrated. We're just trying to get this strip. It's really impeding birth because we're having to stop and interrupt. And so I just wish there was a better way to do that. So when we are actually monitoring the baby for that strip, I assume we're looking to see how well they react and tolerate to the contractions and how fast they rebound and come back to, and then how they respond to like our next contraction. Is that right? And how many contractions are we hoping to see, or like how many minutes should people be expecting of how long they might want to see a strip for?
Like I said, typically what I've been used to, which it can vary, right, from provider to provider, from hospital to hospital, but typically it's 20 minutes. We want to see like a 20-minute strip. Baby looks fine, and take them off for, a couple hours or 40 minutes, or it's different no matter, depending on who you're talking to. But what you were saying is, yes, one of the things that we're looking at, there's a few things that we're looking at, and it can be helpful to know a little bit of what is happening. And because some providers respond differently than others, and so you can sometimes advocate for yourself a little bit better if you're like, hey, I feel like the baby's heart rate's coming back to baseline really quickly, and that makes me feel comfortable to continue on, whatever, right? So some of the things that we're looking at is, like I said, we want the heart rate to look all crazy. We want there to be some jiggity jaggities in there, I guess is what I would call
Yeah.
them, right? And we want to see the baby's heart rate like go up from where it's like sitting typically, right? We want to go up and hang out there for a few seconds, like 10 seconds or
During a
something.
contraction?
Not necessarily during a contraction, just like
Okay.
in general. In terms of contractions and like what we want to see with that, we just want to see the baby's heart rate doesn't drop too far down, and do that over time with each contraction for long periods of time. What I think a lot of people miss, or maybe are not aware of when they go in to have their babies, is that like babies are, when they're in the womb and they're going through labor, it is a stressful process for them. And contractions are squeezing them. They're essentially holding their breath during that time. And they're experiencing that every so often. In active labor, we're talking every 2 to 3 minutes. It's often. And when you're considering that your contraction might be lasting a minute or a minute and a half, that's included in that 2 to 3 minute time frame. So they may only have really a true minute or two where they're getting a real break during those active stages of labor, right? So babies are getting squeezed, and they're essentially tapping into something that we call fetal reserve, which is like this extra amount of oxygen that they have in their blood. It's there specifically for this, right? To help them cope with labor. Babies are so great at coping, right? They're so great at handling stress that if we were tiny and in the womb and having to deal with that, like our adult physiology, we wouldn't be able to handle it the way that our babies do. We can see some dips in heart rate for periods of hours or so longer, depending on how deep they are, depending on how they come back up and little things like that. And it doesn't necessarily mean that anything's wrong. It could just mean that baby's experiencing a intense labor and is coping with it. The times when we worry about baby maybe not coping as well is when the baby's heart rate drops down and then it takes a really long time to come back up. Or baby's heart rate drops down and then it comes back up and it overshoots where they've typically been sitting and they're like up high. Their heart rate's real high because sometimes when we get to the later stages of we've been coping for a long time and we're running out of that reserve, the way that we compensate for that is like to shoot our heart rate super high. And that's our compensation mechanism when it gets a little bit farther down that path. And so it can be helpful to know that because if you see that's not happening, neither of those things are happening, and there's some dips and it's been happening just for a little bit, you can maybe ask for a little bit more time, especially in a case where you're close to the end or you maybe you're on Pitocin and you're like, hey, let's maybe just take a little Pitocin break. There are different scenarios where I think it can just be helpful to maybe communicate that knowledge to your provider. And oftentimes they'll be like, yeah, I guess so.
If you insist.
It's a good point.
I love it. Are there anything, like any tips? Is there anything that you've learned throughout the years that is a really good trick to get babies to chill out if you have a baby that is looking funky? One of our team's favorite things to do is put people on hands and knees. We find that babies, a lot of times, not every time, will relax there as they're just hanging. Anything that you have found that you're like, yeah, I like to do this every time, and a lot of times it works?
Definitely position changes. I don't know if there's any position necessarily that's like this one is going to help because it really depends on what's happening inside, which we just can't know. Even when we like try to feel or your midwife does this a check and they think the baby's this way or that way, we don't know. There's no way to really understand what's happening in there. So yeah, trying some trial and error with positions is usually the biggest. That's the way to do it. We used to give people oxygen when their baby's heart rate would drop. We found in studies that doesn't really work, but position changes can help. Oftentimes it's the baby's umbilical cord maybe getting pinched, or it has something to do with a stressful circumstance that's happening, maybe induced by a wonky position. I would just try it, try a bunch of different stuff until the problem resolves. And I'm not sure if there's ever been a time that I've worked in labor and delivery where those common decelerations are happening, where we can't maybe cause some positive change with the right position change.
Sure. Do you ever find that giving fluids helps or no?
It can, absolutely.
Yeah.
Yeah.
Oh,
Yeah,
yeah.
those two things, like if your baby is having a decel and their heart rate's dropping during a contraction, those are the two things you'll notice your nurse
Oh,
do very reliably is yeah, a position change, and they'll usually give you a whole bunch of fluid all at once. Yeah.
yeah.
But then we used to do the oxygen, doesn't work anymore. Those three things are like it's called intrauterine resuscitation.
Wow. Why do you think the oxygen doesn't work? Because the more we oxygenate mom, it doesn't necessarily result in a better oxygenated baby?
Yeah, your body has been caring for this baby for 9 months, getting it oxygen 24/7, right? Like,
By itself.
yeah. So at this point, if there is an issue with your baby not getting enough oxygen, it's because the placenta is struggling to get that oxygen to baby because of these muscle contractions that are happening inside the uterus. It's not something we can necessarily overcome by just like getting more oxygen into your system. Also, it's like how quickly can you get a surplus of oxygen into the blood that's going to translate into baby getting more oxygen. And it's just there are better ways to address decelerations that work better than
Sure.
trying to pump oxygen into the baby. It just doesn't really work the way we think it would.
Sure. So, what are some scenarios that you maybe would be required or would want electronic fetal monitoring. Like one that comes to mind is Pitocin, right? Anytime we introduce
Oh,
Pitocin, we probably do want to be monitoring baby to make sure that they're tolerating it well. Anytime you have an epidural, one question our team always gets is, what if I decline an IV with an epidural? And I'm always like, they're probably not going to put in your epidural if you decide that is what you want to do. Is the same thing true about electronic fetal monitoring? If you say I'm not going to have continuous fetal monitoring, you think a hospital might say, like, then we absolutely cannot put an epidural?
I think some places would say that. I don't
Totally.
think that it's true across the board for some things where it's like a little
Okay.
bit more of a gray area. If I'm not mistaken, I have seen in places where, yeah, people can have an epidural and not have continuous monitoring. They can have intermittent
Wow.
monitoring. But I would say that it's pretty typical that if you are accepting any major medical intervention, that they're going to watch baby. And
Okay.
it makes sense why. If we're going
Yeah.
to give medications to you and your baby, we have to make sure that baby's not responding dramatically to them or in a bad way. Pitocin is a great example of that because Pitocin causes fetal distress oftentimes. Other big pregnancy diseases like hypertension, we want to watch baby when people have things like that going on. So there are definitely very good reasons to monitor. And yeah, some of those ones are very obvious, like hypertension is a big one. Some of them are more of like a gray zone. But yeah, that's something that we hope that our providers can offer some individualized care and help you make decisions that make the most sense for your situation.
Yeah. So what about preeclampsia? Is that kind of yes, fetal monitoring, or is that a gray zone?
Yes, we would want to monitor with preeclampsia.
Yeah. Because it has that high blood pressure component to it.
Yeah, preeclampsia is a very interesting disease
Yeah.
process. It's not even fully understood, but it's very serious. We know that preeclampsia not only poses an extreme risk to mom, but it also poses a higher risk to baby for things like stillbirth and whatnot. Watching baby just to make sure that there's no issues with the placenta breaking down can be important.
hmm Gestational diabetes, yes, fetal monitoring, or gray zone?
There is some gray zone to that because diabetes in general, gestational diabetes is a whole gray zone. We have people who, for example, maybe weren't diagnosed with gestational diabetes, but maybe almost were. And then we have people who are just barely diagnosed with gestational diabetes that are controlled with diet and they don't need medication, they don't need insulin. And then you have people that are taking insulin and all of that. That is one that we don't always need to monitor continuously. We can do some intermittent monitoring. I think earlier you asked about intermittent auscultation or like use of a Doppler.
Yeah.
That's one of those things where if we're thinking of a spectrum of most aggressive monitoring approach to least, that would be more on the least side of things because we can't see that whole trend, that line.
Oh,
There are certain things we can't gain from that information that we can't get from listening to babies. So, like gestational diabetes, I wouldn't say we could go and do something as, I guess, whatever you want to call it,
kind of
like
like hands off as a Doppler.
as hands off as that. Yeah.
Yeah.
But intermittent monitoring, I've seen that
Wow.
frequently. If
Okay.
baby's looking great, diabetes is pretty well controlled with diet and all of that. We oftentimes treat people like that pretty typical as everyone else. Oftentimes they're there for an induction. So there might be other things that would say, hey, we need to do some monitoring, but they've gone into labor on their own earlier and they're again controlled, all of that. Like a lot of midwives would make the call or doctors would make the call to say, no, we're fine. We don't need it.
Same is true with misoprostol, Cervidil, Cytotec, all of that. You can get your dose, have some monitoring, and then be let off. Is that true?
Yes. Yeah.
Nice.
And again, it's different based on each provider. There's some providers that will not want you to have any time where you're not being monitored continuously until you get to the point where you're ready for your next dose, and then they want to keep watching. But for a lot of them, yeah, you can get your dose and then after a couple hours baby's looking good or however long, you can take a little break and then when your next dose comes restart it again.
Nice. Okay, last one. Meconium. Yes, electronic fetal monitoring or gray zone?
That's a good question. I feel like I don't think I've seen situations where people have had like thick meconium and have ever been okay with like intermittent monitoring after that point. But when it's real thin, I think that's pretty reasonable to advocate for intermittent monitoring if everything else is looking good and there's not another reason. Meconium is very common, especially if you're past your due date. Babies get more mature, their gut gets more mature, and sometimes they poop a little bit in the womb. If it's not a crazy amount, it's not something that really makes us think, oh, the baby's under a lot of distress. It's just oftentimes a result of maturity from the baby. It's when the meconium's real thick that we're like, hey, is the baby maybe under some distress and we want to watch a little closer. Other than that, it's after the baby's born that we're more worried about than while the baby's in utero, because that meconium's sticky and can cause some issues with breathing. But
And would those variations look similar to the ones that we were talking about earlier, where baby just it dips really low and then struggles to come back up, or it dips really low and then overshoots where it's supposed to be? Would that look the same if it was meconium?
typically, if we're talking a situation where we get thick meconium and it's the result of fetal distress, it's typically like significant fetal distress. Like it's maybe the baby's been under stress for a long time, or there's some severe problem happening, like
Sure.
maybe the cord is like slipping out in front of the baby's head or something. And so that's like a very dramatic response to like stress. We don't typically see like a small amount of meconium because of that. So when we're talking about like little dips that are happening with each contraction that get like slowly deeper and all of that, it's not, from my experience, typically correlated with that real thick meconium until
Sure.
we maybe get real far down that road where the baby is like really struggling,
Yeah.
and they're not compensating anymore, they're decompensating, that we see the like real thick meconium.
Sure. So usually when it's real thick meconium, things have led up to that, is what you're saying. It's not
Typically,
our first
yes.
sign.
Typically. Now, of course, there's always exceptions to the rule.
Sure.
There might be circumstances where, I don't know, there's things that can happen in the womb when you have, for example, like your water breaks and the whole environment in there shifts. So there are definitely exceptions, but for the most part, babies compensate with that fetal reserve for as long as they can. And then they compensate with, again, that tachycardia, with their heart rate going really high. And they have different ways to compensate. And then eventually those compensation mechanisms fail. And it's before we get to that point that we want to adjust what we're doing. Obviously, on the other side of the spectrum, it's like we don't need to necessarily intervene or change everything that we're doing based on the beginning stages of these things, because we know that this is how it works. This is how labor is designed to work. So it's like drawing that line. And that's honestly a big reason why you get so much variation in approach from provider to provider, because some providers will see 2 decelerations and be ready to act. Some will be comfortable having you push for hours, and with every contraction, baby's heart rate is dipping because they know in their heart of hearts that this baby's compensating fine. And we're close to the end, and there's more factors that they're pulling into their judgment than just there's a decel.
Yeah, that's a great example of medicine as an art. You're not going to love every artist's painting, so you wouldn't love every doctor's approach. That makes so much sense. And also, I think is such a great reminder of finding a provider that's aligned with you. Just because you've been with somebody, don't stay with them if you don't feel safe in their care. If every time you leave your prenatals, you're like, dang, that could have gone better. Or like, man, I wish I had said this. Or gosh, they hurt my feelings. I didn't feel very heard. You should definitely change providers if you can to find someone that is better aligned with you. You brought up your waters break-in. If someone is having continuous monitoring or they have intermittent monitoring and their water happens to break while we have the monitors on, are we expecting to see some sort of predictable variation in baby's heart rate where we, kind of we say like, all right, that makes sense because your water's broke. Maybe we shouldn't intervene right now and just monitor baby, or baby's heart rate stays the same during water's breaking?
Sure. Yeah. Sometimes nothing changes. And a lot of it has to do with like, how does your water break? Does your water break in a way where baby's up high and it breaks in a dramatic way where like you've got this big tear of the bag of water, so you have all the water rush out at once? Or, is baby lower and maybe their head, pressed up against your pelvic bones is occluding that, way out so the water can't all leave at one time? Because you have to think that in the womb you've got this bag of water, and with those contractions that are squeezing, that's really offering a buffer. It's offering a cushion to your baby. So if you lose all of your water at one time versus if you still have a lot in there, you're getting this slow trickle and all of that, you can see maybe differences in the way the baby responds. In a scenario where almost all the water is gone and the baby doesn't have that cushion anymore, I can expect that there will likely be some changes in their heart rate, and they might not cope with labor as well as they did because they don't have that cushion. And so that's not necessarily a reason to intervene, just to keep in mind. What I talked about earlier with a cord slipping out, that is one of those things that like we want to be mindful of. If your water breaks dramatically, sometimes it can be a good idea just to maybe check on baby, make sure that they're still doing okay, because sometimes the cord can slip out when the water is like a big gush. But yeah, generally there's not a lot of changes that need to happen when your water breaks, except yeah, it's a good idea to think about, yeah, my baby might not be as perfect and pretty on the monitor as they were before your water breaks, and that's normal.
Sure. Yeah. Which is all the more reason I'm very open about this bias, Caitlyn, on the podcast, just like in general, but I feel very strongly about amniotomy and that it is very rarely needed and it very rarely plays a good role. Sometimes, and I have seen it do good things. I really have. I'm not anti-amniotomy. I just use it with caution. I've seen it do a lot of really bad things and it's disrupted a lot of labors. But it just reminds me, this is another reason of consider this when thinking about amniotomy is if your baby's tolerating labor really well and we don't have a medical reason to do amniotomy and or we have other alternatives, we could save amniotomy or your water's breaking naturally for later, maybe consider that. I didn't know that. Very cool.
Yeah, I really do feel like you have a toolbox, and this
Yeah.
is especially true for induction. You have a variety of things that you can do to encourage the body to do what we want it to do. But in reality, our body and labor in general is not something that we have been very successful in controlling, which is part of the beauty of it, that it's one of those things that no matter our best efforts, we can't wrangle it. That's cool in one way, but to keep that in mind, that like amniotomy is one of very few tools that you have, and in some cases it can be a great tool, but as you were saying, yeah, you can cause a lot of problems if you don't use it strategically or maybe avoid its use in the cases when it's really not necessary or doesn't make sense, because you're like I said, like even just breaking the water and having the umbilical cord slip out, that's scary in cases where we did not need to break the water, where we could have let the body do it on its own, because what the body will do is it usually will have those contractions, baby will move lower and lower, it'll force baby down into the pelvis, and then the water isn't likely going to break, at least not in a dramatic way, until the baby is like pushing against that bag of water trying to make its way out. And in that case, your baby is locked into your pelvis and there's no cord that's going to slip out in front of your baby's head. But when we start putting our hands into things where maybe they don't belong, we break water maybe before the baby is low like that. And then things happen that should have never happened. So we just have to be careful. Anytime that we touch it as humans, when we start touching natural processes, we can sometimes make them better, but if we're not careful, we can make them way worse.
Yeah, I really resonate with what you said about it's cool we can't wrangle birth. I love the mystery of birth. I love how every birth is so different. It's for me, it's like a puzzle piece, and you're never gonna have all your puzzle pieces until you get to the end of the story. But there's always sliding pieces. There's always new pieces being added in. There's always pieces you're like, oh my God, we dropped that piece over there. We got to add it in. I love the mystery of births. I'm really glad that you brought that up. All right, Caitlyn, I'm out of questions. I feel like I've learned so much and I feel like I knew a lot coming to this conversation already. Is there anything else that we should think about when it comes to any sort of electronic fetal monitoring in labor? Continuous, intermittent, Doppler, paddles, whatever it might be that we didn't cover that you think people should know?
No, I don't think so. I think just, yeah, knowing like all the different options, the intermittent auscultation, you have continuous monitoring, but you have different versions of that. You have the portable version, you have the stationary version, and then you've got your intermittent fetal monitoring, and kind of understanding again those two pieces there of what is it that I'm gaining from this selection. Am I gaining a little less oversight? I'm not as much under the microscope. I have freedom to move around. Like these are different things to think about. And the right answer is not always going to be the same for everybody. Sometimes more medical intervention. I know I tend to lean, you tend to lean, I'm sure, on the side of less intervention is better. But for some people, more medical intervention causes an ease of mind and it helps. It's really just about choosing the one that makes the most sense with what your values are, what you find important.
Ah, all right, you guys. Now you see why I love her so much. Caitlin, thank you so much for coming on the show, truly. And I got to come to your maternity store opening a couple of months
Yes.
ago. So can you tell everybody about your brand, your labor gowns, where they can connect with you online, but more importantly, where they can buy your gowns because they're so comfy, you guys. It's the teal gown that I wear in all of my little role-playing skits on Instagram and TikTok. You guys, it's so soft and it has all the bells and whistles. If you need it in labor, Caitlin has thought about it and put something on or in the gown for that. Tell us where people can find them and all about your brand.
Sure. Yeah. So I started my brand like completely on not a whim, but I did not intend to start a brand. I literally
Yeah.
designed a birth gown that's a functional, like it opens, it's got all the little, like you said, bells and whistles for you to be able to use it in the hospital without having to wear like the hospital gown. It's an alternative to the hospital gown. And I used to just give them away to my doula clients. But then, yeah, TikTok had other plans for me. So I started a brand and now we've got 4 different versions. So everything that, there's a gown for you. We have 25 different colors and a bunch of different versions. And they open for skin to skin, for breastfeeding, fetal heart monitoring, how we talked about it's a constant struggle sometimes to keep the baby on the monitor and move the monitors around and your nurse is coming in every 15 minutes. It makes it nice when you don't have to lift up your hospital gown, expose yourself to the room and a bunch of strangers. You can just open it in the front. There's ties to help keep it closed. It's got a low back for epidural or for massage or for TENS unit. It's got everything and it's comfortable and soft, so it's not going to irritate your skin because textures can sometimes be irritating when you're in labor. And it's stain resistant, so you can wear it and not throw it away. Please don't throw it away. People are always like, I'm not going to buy something that's this pretty or nice or whatever just to throw it away. Don't throw it away. Wash it and then wear it postpartum and then bring it to your next birth and then bring it to your doctor's appointments and wear it to your well woman or whatever because it works as an alternative to any hospital gown or just even like a robe to wear around your house.
It's literally
yeah,
so buttery soft, you guys. I cannot tell you how soft it is. It really is amazing.
But yeah, you can find it at my website. It's www.wearlila.com. And yeah, that's about it.
Where can people connect with you on TikTok?
Yeah, so TikTok's my main kind of, I share all sorts of stuff, not really even predominantly about my company or anything, but really just like childbirth education, funny things, relatable things, stuff about my own life. It's at The Modern Midwife on TikTok. And then if you want to follow more of just like my company and like what we're doing, what we're trying to do for moms and parents and families all over the place, that's on Instagram at lila.laborwear.
Okay, and you also have a childbirth ed space in your Leela maternity store. So people in the Tennessee area or anywhere in the southern region, if you want to drive for some good childbirth ed, you have a childbirth ed class in your store. Is that right?
Yes, that's right. Yeah, I'm trying to create like a hub where you can get all of the products that you need, clothes, all that stuff, and also like childbirth education, just like a place where you can get all the support that you need, all curated by someone who has spent a long time in this field and kind of knows maybe the stuff that's great and maybe the stuff that like you don't maybe need as much.
And
But
you're a
yeah, we
mom
have a
of
nice
three.
classroom. We're doing it all. What was that?
Yeah, and you're a mom of three, so you've done this a time or two.
Yeah, that's what I'm trying to do. We'll see if it hits or if it sticks. It's brand new. We've only been open for a couple months. We'll see. Wish us luck.
I know it's going to stick because it's a great idea. It's just awesome. And I think that people in Tennessee could really use it. Your turnout for the opening weekend was amazing. I was so blown away by just the support and all the people who came out to love on your store and just love on you. It was amazing. I was like, oh my God, Caitlin has created such a empire here. It's amazing. So thank you for sharing your wisdom with us today. Thank you for loving on the people in Tennessee and for teaching all of us so much on TikTok. I know I learned a ton from you there. And I think that's it. So listeners, I will see you again in the next episode. Until then, find me on Instagram or YouTube. Bye. Thanks for joining us. I'll see you next time on the Birth Lounge podcast. Until then, head over to Instagram and find us at Tranquility by HeHe and give us a follow. You can also check us out at thebirthlounge.com.